Hi, everyone. Welcome to the Livelong podcast. Here, we believe your health is your power. My name is Erin Hunter, and I am the senior editor here at Livelong Media. So, I am joined today by Dr. Sophia Yen, and she is an adolescent medicine specialist with Stanford Medicine Children's Health and the CEO and co-founder of Pandia Health, a women's hormonal health platform which matches your hormonal care to work for your biology. So, we're going to be going through hormones today. This is the cornerstone of all of women's reproductive changes, and it's what Dr. Yen calls the ultimate longevity hack, hormone therapy. So, we're going to explore birth control too, myths about hormone replacement therapy, perimenopause, menopause, everything you name it, we're going to dive into it. But real quick, before we do that, I would just like to say that less than 100 days from now, you could be part of one of the most awesome women's health events that we've had so far. So, the Women's Health Summit is coming to San Francisco on the week of April 17th. And ideally, we are going to help you build your capacity to move better, live better, and protect your independence so that you can age to the best of your ability. So use the promo code Erin and get money off of your ticket at checkout. So get that today. Now, without further ado, let's give a warm welcome to Dr. Yen.
Hello, and thank you so much for having me here. I'm really excited to share my knowledge and passion about how HRT, estrogen, progesterone, MHT, MT, however you want to call it, is the greatest longevity hack.
All the T's, all the T's are for longevity. It's going to be an amazing conversation. And to start off, you talk about it as a longevity hack, but I want to know what you mean by hack. What is the hormone replacement doing that's hacking your system to help you fundamentally live a longer life?
So the way that I look at it is at around 52, which is the average age of menopause. Your body's like, thank you for your service. We're taking away your estrogen and progesterone. Go out to pasture. And as soon as that estrogen goes away, everything goes to poo. And so it starts a little before that last thing because it isn't just like on off. It's like a slow progression of nothing. And so I like to say it's like running out of gas. You can run out of gas like put, or it can just be bleh. And so that's perimenopause, that process of your ovaries trying its last flail, its last song. And when that estrogen is taken away, very importantly for your health, your arteries no longer dilate. Your arteries fill with cholesterol, LDL, HDL is good stuff. LDL and triglycerides shoot up. And then fat goes centrally. So that's called central adiposity, goes to your waist. That's why your pants don't fit or your skirts don't fit, or your waistline disappears. And then, more importantly, I'm also an obesity expert. The fat deposits viscerally, so it goes into your liver, it goes around your heart. And when I hear that as a doctor, I'm like, you don't want that. So, if that's what happens when you take away the estrogen, you want to put it back. And then also before that, your bone density goes down. And so that increases your risk for bone fractures. And it's not just some wimpy fracture. If you get a hip fracture, there's a 30% chance you will be dead in the next couple of years. So I want to live as long as possible, as healthy as possible. I want my mom to live as long as possible, as healthy as possible. So we all really need to avoid osteoporosis, but the number one killer of women is heart disease. And so these heart effects of not having estrogen are so important and such huge numbers. So it's estimated that 50% increase risk in heart disease if you're not on HRT, and that we could prevent 60% of fractures if everybody was on HRT. And there's a 24% increased risk of colon cancer and a 21% decreased risk of diabetes if you're on HRT. So many health benefits from being on estrogen to prevent all of these things from happening. And so and then people are like, well, it used to be the smallest amount of estrogen for the shortest amount of time. But if you ask any menopause society certified practitioner, we're like, you're going to find this patch on my dead body. Because if you stop 10 years, because some people like do it 10 years and then come off, I'm not just going to all of a sudden manifest estrogen. And so if I stop at 60, all the bad stuff that was going to happen at 52 is now going to happen at 16. So unless we all of a sudden manifest estrogen, you need to be on that until your last breath.
So the estrogen, let's say a woman had been prescribed it, she takes it until age 60. That doesn't the way it works isn't that it triggers the production of estrogen again, nor does it stay in a reserve. It just fundamentally goes bye-bye.
It's a supplement. It's just
Mm.
putting back what is missing because your ovaries like, I'm done. And actually, it even affects, we know it does, the vagina. And I just came up with this last night because there's genital urinary syndrome of menopause. I didn't come up with that, but that exists. And in that, your vagina becomes dry. It loses its rugae, which the rugae allow it to extend, and so I call it sandpaper sex, but I just realized the vagina is like, I'm done having children, so close for business. And
Mm.
so by have it's like, and that's it's the eggs. The eggs no longer happen, and the whole popping of the eggs and all that stuff is what is causing the estrogen and progesterone. And so as we all know, once you're beyond 35, your eggs qualities are bad and your eggs are fewer. And so it's like the I'm done with making babies. And so thank you for hanging around being a grandma for a bit and now out to pasture, aka you should be done. So anything above 52, I always say is gravy and has to be biohacked.
So there are recommendations that women who have gone past a certain amount of time post-menopause, there are recommendations that maybe they should get hormone replacement therapy. That seems like a bit of a letdown, considering, okay, if it has all these benefits, am I just screwed if I didn't get it within the allotted amount of time, which was 10 years? That's what the recommendations are. If you're 10 years out of menopause, it could be dangerous. What is your take on that?
Yes. So the key is to understand the latest evidence and science. And so what it is if you start HRT greater than 10 years out, imagine as I described, you take away the estrogen and your arteries get hard, they fill up with cholesterol, and then you add estrogen, which is known to cause blood clots. What's going to happen? You're going to
Mm.
have a heart attack, have a stroke, have a clot in weird places. And so that is the danger of starting it because you let all this stuff accumulate for 10 years and now you throw estrogen, which is known to cause clots. And so it is the new thing is shared decision making, a decision between you and your physician. So if you come to me at 60 and you tell me your cholesterol is normal, and you have a CT cardiac scan, that's the new hot thing, may or may not be covered by insurance. Probably not, and probably costs like $200 to $300 or something like that if you can get it at that price. Then if that is clear and it shows, oh, her arteries aren't filled with crud, then I'd be like, okay, I'm willing to take this risk with you. Mainly, it's physicians are afraid of getting sued. So if you sign a piece of paper that says, if I have a heart attack, stroke, or anything bad happens because I decided to take estrogen, me, my family, etc., will not sue you, then a doctor would feel comfortable because I'd be like, well, it's a risk benefit, thing. And if I give you estrogen, then it helps with the cardiac thing. But even now, people are saying we don't have enough evidence to show that it prevents cardiac, but I think the evidence is there. And I asked the cardiologist, how much evidence are you going to need when we know when you take away the estrogen, all this bad stuff happens, to say that we can use it for prevention? Right now, the four FDA approved reasons to treat with HRT are hot flashes, night sweats, genital urinary syndrome of menopause, and at risk for osteoporosis.
Mm.
noticed that cardiac was not in there. But the whole reason we started this HRT thing was they noticed that women had their heart attacks 10 years after men. And the first people that they tried HRT in were men. They gave them estrogen to see if they could put off their heart attacks until age 60. Unfortunately, it didn't work because men have different physiology going on in their body. But we see the benefits for women when you're on HRT. So, to say one thing to note one, anyone of any age can have vaginal estrogen because vaginal estrogen is not absorbed systemically. And so it doesn't have the risk of these blood clots. So, systemically means it's running in your blood all throughout your body. Vaginal
Mm.
estrogen just affects the vagina, which allows you to decrease your risk of urinary tract infections because it also helps the urethra, and then it prevents this sandpaper, painful, ripping sex. So, anyone of any age, and we absolutely recommend the urogynecologists recommend that anyone 52 and up should just throw down some vaginal estrogen at a minimum to prevent recurrent urinary tract infections. So that's number one. Number two, we now use transdermal estrogen. And when it goes through the skin, it doesn't go through the liver. If it goes through the liver, that increases your risk of blood clots. But by going through the skin, there's a much lower increased risk of blood clots. And in fact, we feel there's no increased risk of blood clots. And so this whole blood clot thing may not be an issue with the transdermal.
And that's no matter the age.
Yeah.
Okay, wow, wowness. That's pretty cool. And it feels pretty hopeful, I think, for everyone and inclusive. It's so, what I'm understanding is that hormone therapy is quite inclusive for people prior to menopause, during menopause, post-menopause, till, as you said, you're in the grave, like you wanted forever. But one thing I want to touch on, and this is something you've talked about, is this area of premenopause. So perimenopause, it's the puttering stage of your estrogen and your sex hormones. So during the puttering stage, you've also said that the best treatment is birth control. That seems pretty counterintuitive to hormone replacement therapy. Like instead of the replacing hormones, you're just saying, no, like let's stop them, stop doing it. So, can you really explain what the healthy aging and longevity benefits would be for younger women who aren't quite there at menopause yet?
Yes. So many people have started to be educated on menopause and they hear about bioidentical estrogen and progesterone. And just as an aside note, bioidentical estrogen and progesterone, there is FDA approved, FDA tested bioidentical estrogen and progesterone, and it's your standard HRT, MHT, MT. You do not need compounded and you do not need pellets. And anyone who's doing pellets is not doing standard of care. That is not FDA tested, not FDA approved, and the levels that we see there are often super physiologic. The compounded generally does not need to be done, and it's just someone trying to make more money because it costs more money to compound something and it expires faster. So it
And
doesn't have.
just to clarify, to compound something means to make something that's just as effective as the real treatment, but with different ingredients and a
The
different mixture.
compounding means that you've taken something and you've mixed it at a different level, or you've mixed it with something else that it wasn't originally FDA approved for. And
Mm.
the issue with the compounded is you got to find a special pharmacy that can compound these kinds of things, but also that formulation has never been tested on a large scale. It's probably okay, but it's probably unnecessary. Most people can get by with the four different levels of estrogen that come in the patch. And if you're doing the gel, you can probably customize it a little more, how many pumps you do or something like that. So that's why, in general, American College of Obstetrics and Gynecology and the Menopause Society of North America do not recommend compounded unless the other stuff doesn't work for you. But generally, most people do great on that, and most Menopause Society certified practitioners are not prescribing compounded. Um, But back to what you were saying, so important for people to understand that in perimenopause, your hormones are chaos. It's up and down, up and down, up and down. And so you do not want to add estrogen on top of your high estrogen, because if you do that, you're going to have the effects of high estrogen. And the inconvenient stuff is headaches, breast tenderness, but the dangerous, bad stuff is that the headache is indicating that you have high estrogen. And as we mentioned before, estrogen means blood clots. And so you could be
Mm,
having a blood clot in your head or your heart, but more importantly, it also stimulates your uterus lining, and that increases your risk of endometrial hyperplasia, which then increases your risk of endometrial cancer, which is
mm,
cancer of the lining of the uterus. And so that's why most physicians will recommend in the leading up to menopause that rather than add estrogen on top of high estrogen going through this roller coaster situation, we take it over with the birth control pill or the birth control vaginal ring. And that just stabilizes nice, smooth hormones because it is the drop in estrogen or the up in estrogen that is going to give you the hot flashes. And so it's better to be smooth than up and down. And certainly your body, your choice. If you love roller coasters and you want to do that, go for it. But generally, the birth control is a 2 for 1. You take over this chaos and smooth it out, and then you are capable of being pregnant until menopause. That is the whole point of menopause. We don't diagnose menopause until 1 year after your last period because during we don't know whether you're going to randomly throw out an egg until you haven't thrown out an egg for a year. And
mm,
that in your if you can randomly throw out an egg, you can randomly get pregnant. And there have been some oopsie babies in 50, 52. 52 is the average age of menopause. Some people go out to 56. And so you could have a baby at 56. So very important to use birth control. And so nice to have a 2 for 1. And for me, that's what I did is I was on constant hormones. And the way that I knew that I had entered menopause was not hot flashes or night sweats because the high estrogen progesterone in the birth control pill covered that. And I was having smooth and no sudden drops, which is what triggers hot flashes and night sweats. But it was the genital urinary syndrome of menopause, the sandpaper sex, as I call it. And
mm.
then my waist disappeared and my cholesterol shot up. So this is the thing is I'm a doctor, a total doctor snob. I picked the best and the brightest doctor I could find in Palo Alto. So 52-year-old Asian American shows up in your office on the birth control pill. Her waist disappears, her cholesterol shoots up. What does my doctor tell me? She puts her hand on my shoulder and she goes, "Oh, it's old age. You need to exercise and you need to eat healthier." And what she didn't know is I'm an obesity expert and people wait 6 months to see me. And I had not changed anything in my diet or exercise. Like if I were to take travel to Hawaii or New York, I'll pig out. Sure, but it had been a very boring month for Dr. Yen. And last year, cholesterol totally fine. This year, triglycerides off the scale. And so this was before I became a Menopause Society certified practitioner. But once I took the test and studied up on the latest and greatest, I learned that the waist disappearing and the cholesterol shooting up is what happens when the estrogen goes away. So I switched from the birth control pill to the bioidentical estrogen progesterone, and then my waist came back. And
Wow.
yeah,
Did your cholesterol drop as well?
the thing is, she put me on a statin, and from the biohacking, live as long as possible, the joke is there's no such thing as too low of a cholesterol. So I was like, one's on a statin, not coming off. So didn't check it without the statin, so I can't say. But I definitely noticed all the things get better, brain fog as well.
Mm.
And so that's how you know you get the other symptom. But I didn't have to go through hot flashes, night sweats, which I think is, and whack bleeding. So I want to go over whack bleeding, or lay people call it flooding. A physician wouldn't know what you were talking about, but just heavy menstrual bleeding. Women who have not bled all of a sudden will get random blood because of this puttering if you do this naturally. And I had two friends, not like I heard about this, but two friends. One went on a trip to Africa and had crazy blood, like murder scene blood. And you're in a foreign country and you don't have your products and you don't have your doctor. And like, how horrifying as a professional businesswoman to have murder scene blood while you're in a foreign country trying to entertain people, right? That's one. I had another friend, and this is all before I went into menopause. If I had known, I would have helped them and treated them, but they told me this before. And then this other woman, for an entire month, she couldn't visit any friends because she was afraid that if she sat down on your furniture, she would destroy it. It
Oh,
might leak out, right? If you leak blood on your friend's couch, what are you
oh,
gonna say? If you leak blood anywhere in someone's house, what are you gonna say? Unless they have plastic sheets or you're sitting on their floor, then you can clean that up. But any cloth you're gonna destroy. And I was like, girl, anybody who bleeds more than 7 days in a row or crazy amounts of blood, please see a doctor. We have drugs, we have science. Let us help you. Don't be all sad, but also you can get anemia. Some people have had transfusions, or if you're feeling tired and cold because you lost a ton of blood, that is iron deficiency, that is anemia. The number one cause of anemia in a menstruating woman is menstruation. So the take home
wow.
points is you do it naturally, you might bleed like stink and have this flooding, which is lay people term, or you also can have, these hot flashes, night sweats. So why not just do it smooth as opposed to up and down, up and down? And
Then instead of
someday,
riding the roller coaster, you're just on the stream, right? We're level, we're bobbing in a tube, just like down the river. Now, so the thing that strikes me here is that you say you are a menopause certified practitioner, and that is an MSCP. So what in you're talking here about like you have an insider scoop. The doctor won't know a flood, but you know the flood. What are some of the other insider symptoms and things that women should keep their eyes out for when it comes to what, like these unexplainable symptoms? Is there anything you see that the doctor would just discredit, but it's actually related to the hormone journey?
yes. So I think the key to know is that 69% of OB/GYN residencies today, not like 20, 30 years ago, back in my day, but like today, have no menopause curriculum. They did a survey of the OB/GYN residencies, and of the ones that responded, only 31% had some curriculum. And some could be a day, could be an hour, could be a month, could be a week, whatever. I don't know. It was, vague in its definition, but 69% had none. So who knows what your internal medicine, your family medicine doctor has? And doctors really want to do good in this world. So they're all learning, they're all studying up. But what happened was the Women's Health Initiative. That was announced in 2002 before they ran the numbers by their colleagues, before it was scrutinized and looked at, is this the quality that we would publish in the New England Journal or something like that? It was 2025 of the greatest researchers. So nobody questioned this group of people when they said, if you take HRT, it increases your risk of breast cancer. But when they finally analyzed it and published it, it turned out that in the group that only got estrogen, because if you don't have a uterus, they didn't give you progesterone, they just gave you estrogen because the estrogen stimulates that lining. The progesterone blocks that lining from getting out of control. So the group that didn't have a uterus, they only gave estrogen. That group had decreased breast cancer. And if they got breast cancer, had decreased risk of death from breast cancer. So it is not the estrogen that increases your risk of breast cancer. We now believe it's the synthetic progesterone. And that synthetic progesterone is no longer used in HRT, MHT, MT, however you want to define it. It is medroxyprogesterone acetate. Generally, people are prescribing bioidentical micronized progesterone known as prometrium. And so And there's been no increased risk of breast cancer with that.
So all that to be said too is that uh, basically the take-home message is just take the HRT nowadays because it's better quality and it's gonna help you live longer and age better. And you can do it at any age if you talk to your doctor and do it the right way and basically follow the current science. And also birth control at perimenopause, contrary to popular belief, because we don't want that roller coaster to go higher. We want the roller coaster to go down. So much myth busting here, so much talk about hormones and health and aging and not having sandpaper sex. It's like all these things that are quality of life. Now, in your professional opinion, as also an obesity coach, what can women add to their hormone therapy? What can they add to their life to make life even better besides just taking a pill and calling it a day? Do you know of any specific interventions like lifestyle, diet, easy peasy that we can should listen to basically because the science says so?
Absolutely. So, the HRT, again, just to clarify, generally is a twice a week patch, is what a lot of us prescribe, and then a pill, which is the micronized progesterone, because that's the only way it comes. If the bioidentical progesterone could come in a patch, that would make me much happier. But I believe the current things that are combi are always the synthetic progesterone. It's not that one, but it's a different one. So maybe different risk of breast cancer, but the bioidentical estrogen, progesterone only comes as a pill. So unfortunately, you got to do two separate things. But in terms of waist and obesity, if the bioidentical estrogen is not sufficient to bring back your waistline, definitely there are changes with age, and we need to eat potentially fewer calories. But in general, I like the old plate model, which is it's a plate model. Think of every meal on a plate. Half of the meal has to be fruits and vegetables, a
Mm-hmm.
quarter of it minimum protein, a quarter of it maximum carb. And what's radical is what I call protein first, protein forward. So as a Taiwanese American, we always have rice and then we put everything on top. That's too much rice. So you need to start with your chicken, start with your salmon, start with your beef and broccoli. And only as much as you eat chicken do you get rice, which is not the standard ratio. And we need to think of pasta as a side dish, not as a main dish. Or if you do it as a main dish, you do this much pasta, you double it with vegetables, throw in vegetables, and then you throw in equal protein. That is the optimal ratio of doing things. And then failing that, I tell people I'm on Facebook groups and I'm like a little touch of metformin. So
Mm.
metformin treats insulin resistance. And what happens when you take away the estrogen, insulin resistance happens. And that leads eventually to diabetes if you gain enough weight. But with insulin resistance, your triglycerides shoot up as well. And so metformin treats insulin resistance. It's used to treat diabetes, but there's been research shown that if you have a family history of diabetes, and almost everyone has a family history, somebody, grandma, auntie, dad, mom, somebody has a family history of diabetes, then they've done in adult studies that if you put adults on metformin that have a family history, you prevent diabetes. So you can invoke Dr. Yen, obesity at Stanford, said that there are research studies that if I have a family history of diabetes, that if I take metformin, it can prevent diabetes. And so, also as an aside, for weight loss, they've shown that metformin, 500 milligrams twice a day, either one tablet twice a day or two tablets twice a day, depending how severe the situation is, can help you maintain your weight. Not lose a ton of weight, but maintain your weight. And not the extended release. Because people like the extended release, you only got to take it once a day. It's a cool thing. But somehow that extended release just wasn't enough. You need to like hit it twice a day. And so I have metformin and I'll just take one or two a day. I don't think I need two twice a day, but I do think your metabolism changes obviously at a 52, and it's probably your body's like, thank you. So we know about estrogen and progesterone, but the metabolism part we might be able to treat with metformin. And then anyone doing GLP-1, if you can make the changes necessary after you've lost that weight at Stanford, um, oh, Dr. Pratt, who we stole from Harvard, came up with 60, 60, 60. 60 grams of protein a day, 60 ounces of water a day, 60 minutes of physical activity a day. And it doesn't have to be all together. It could be 30, 30, it could be 20, 20, 20, it could be even 10, 10, 10, 10. Every hour you just take a 10-minute break and do some exercise. Um, then I think if you lose the weight on GLP-1, you do the 60, 60, 60 for life, and then we throw on some metformin, I think you can come off the GLP-1.
Wow. Wow, wow, wow. What nuggets of food for thought for all of our listeners, and especially those to understand that there's more to it than just the hormone replacement therapy. There's other factors to think about as well. And I really like the 60 60 60 because it's easy to remember. Like, wow, that doesn't seem so difficult. I could do 60 60 60.
Yeah.
Wow, that's amazing. Now, just to wrap it up, one quick fire question. What is one shift you've made in your life after having gone through menopause and after gone through life, really, even as a doctor? But what's one simple change you've made to your life to live better?
I'm so glad you asked because I felt bad I didn't address muscle building. So the
Mm,
new thing is you're working out not to lose weight, but you're working out to build muscle. And that is really important because the muscle pulls on the bone and stimulates the bone to be strong and to grow and to be there. So you have to do the weightlifting, you have to do the muscle building. And I'm seeing it in my parents, this functional exercise to make sure you can get up and down and stuff like that. And I want people to know you don't need to go to the gym. I don't believe in a gym membership. I believe in getting exercise in my everyday activity. So on a Zoom meeting, you can be pedaling your legs. You could be on a treadmill. You could be at a standing desk. Yes. And I'm on a Zoom meeting and I have a chair and I'll just do arm lifts, on my chair, and I'll be like doing leg lifts on my chair. So know that you do not need a gym because so many people use that as an excuse. I gotta go to the gym. I gotta drive to the gym. I don't belong to the gym. I can't afford the gym. As long as you have a body and you have gravity, you have a workout machine. And the example I give is Jackie Chan has a bio, and he lives unfortunately in an attic, and he just has a chair and his body and he's working out. And if you don't have weights, we all have a bottle of water, we all have a backpack. People are like, the new cool thing is to wear a weighted vest, and I was like, just wear a backpack, man. Like that is a weighted
keep
vest,
it
right?
easy.
Yeah, don't buy things. You don't have to. Though my daughters love their yoga mat, and my husband and my daughter love their, 10, 12 pound weight. That's fine. But I got backpacks, I got books, I got water bottles, and so really it is doing more of the weightlifting, focusing not so much on the cardio, though certainly the cardio if you're trying to lose weight.
Mm,
But for bone and body, really it's about muscle. And know that for obesity wise, you have to do physical activity every single day. If you do Monday, Wednesday, Friday, you lose the effect on Tuesday, Thursday, Saturday, Sunday. And it doesn't have to be the same level. You could do something Monday, Wednesday, Friday, and something Tuesday, Thursday that's far less, but that's 60 minutes. And I tell my patients it's that commitment. And so if you haven't done the 60 minutes before you go to bed, you don't go to bed. You do the 60 minutes
oh
and
my
then you go to
gosh.
bed.
Oh, you are a harsh doctor. My goodness.
Easy to say,
Wow.
easy to
No,
say.
that's interesting. No, that's and the more important moral of it is you touch on the discipline aspect and the as the
Commit.
commitment part. Right. And the whole thing I'm hearing basically is no excuses. You've got arms, you've got a chair. Do something.
Yes. No excuses, man. You just got to commit to it.
No
And then
excuses.
as an aside, the metformin has been magical for one patient. I think it's metformin is used for polycystic ovarian syndrome, which affects 1 in 10 women. So if you have PCOS, the metformin may do a lot more for you than maintain. I actually have a patient lose weight on metformin and metformin alone. And I was like, you go, girl. But she also made lifestyle changes.
Oh, wow. That's it's individualized as well.
Yeah.
So what I would also it's like she's one patient and she's a great testament, but it works for everyone, even if it's to a lesser degree, it still is functional. But it could be more functional, is
Yeah.
like what we're saying too.
Yes. That's what I'm.
Wow. Thank you for your time today, Dr. Yen. This was fun, and I appreciate that you're providing a lot of color and imagery and addressing these potential taboos like sandpaper sex, which I know women might want to be like, la 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 la. But hey, if something's real, it has to be talked about, right?
Yeah. Yeah.
And I appreciate your extra insights about lifestyle because as it goes, the way you live your life is the cornerstone of health. It's the cornerstone of longevity, aging, and really enjoying life. And so I appreciate you giving just a full, well-rounded picture, and this was a great conversation.
You. And I just, sorry, one more thing. To find a Menopause Society certified practitioner, go to menopause.org. It's a nonprofit, and they're there to train any physician. So if your physician doesn't know their stuff, they can go there and they can learn. There's free education, I believe, there. And they just got a grant from Mackenzie Scott. Thank you, Mackenzie Scott, for a free educational grant for providers to learn more about menopause. And then, of course, Pandia Health. Please check out our YouTube. We have some lives on there that are really good with Dr. Hansen, who's an OB-GYN with 20 plus years experience in menopause. And then I can do basic menopause, perimenopause 101, but she is the OG. She is such a lovely woman. So please follow us on all the socials, Pandia Health, Pandia Menopause. And I'm trying to build my TikTok. It's Dr. Sophia Yen.
Perfect. And I want to add that I'm making a note to add that menopause link to the show notes so that people can just click on that and get the provider educated information. Um, Excellent. Amazeballs. Thank you for being here. I appreciate it immensely.
Thank you so much for having me.
Thanks.